when I talk subsequently, we would have something to refer to. So it's a rare tumor. Hence, there is no level 1 evidence for anything that I talk or anything for that matter anybody speaks, because it's all based on retrospective data and one's own institutional, country, or personal experience. And the primary treatment in all these is wide excision, and it might just amount to a radical mastectomy at the most. And it should be understood that nothing works other than surgery. Primary treatment remains surgery. And this is what the Hugginson's book, the last edition that came in, as well as the breast disease that came up from Memorial Sloan Kettering, had somewhere in 80s and 90s as the recurrence rate, that benign phyllodes has a recurrence rate of 10 to 17%, borderline between 14 to 25%, and malignant between 23 to 30%. Essentially, it is local recurrence. A small percentage of these individuals can also have distant recurrences, but that's uncommon. And I must read out a comment that comes from the pathologist as late 90s. Despite varied microscopic criteria studied, including grade, their ability to defining malignant potential vis-a-vis clinical behavior remains limited. So we might say that there is a classification that tells me it's benign, borderline, but there are recurrences in benign, which is unheard of in any other benign tumor. And the choice of resection could be either enucleation, wide excision, or block resection, as we do it for sarcoma. There are various prognostic markers. In the previous talks have also dealt with this: age, tumor size, surgical extent, mitotic activity vis-a-vis grade, or the kind of WHO classification that's there, which includes that, and the subsequent stromal growth and cellularity. The surgical margins, strong debate about that. And additionally, the role of adjuvant radiotherapy remains unclear. There are people who vouch for more than 5 centimeter tumor being treated with radiotherapy as an adjunct, and systemic therapy is completely ineffective. That's the WHO classification delineated in 1981. And I must say that after 20 years of use of that, in 2000, the comment that I showed earlier still stands, that we are unable to be 100% certain as to who will recur, who will not. There may be a graded reduction in the recurrence as we go from malignant to benignity, but that's just there. That doesn't rule out that there won't be any recurrence. Clinically, as a clinician, what I want to do is a large fibroadenoma in phyllodes, whether there is anything that discriminates between the two. And within that, a great majority of them we could easily decipher by a core biopsy, but there could be histological surprises when the whole tumor goes for pathology examination, and then we are at it again. Should I do some more excision? Should I do something or not? But the accuracy of core biopsy remains pretty okay. We have the diagnostic accuracy anywhere from 82 to 93%. I must say that all through, I have always relied on the amount of vascularity that the tumor has, the internal as well as on the surface, and that has stood in good state all throughout in deciding whether this is a fibroadenoma or a phyllodes tumor, especially when fibroadenomas are larger. But again, as I said, there could always be a surprise in histology, and then we are fraught with the decision as to what to do. There are many other molecular markers that have come up, right from P53 to MED12. All of them remain and sit on the fence. What I would be interested in, whatever that is, if there is a suspicion of phyllodes, what's the surgical plan? and how to reduce local recurrence. Should we apply the rules of breast epithelial cancer or soft tissue sarcoma? What is it? Is it one or the other? And is conservation an option at all? How wide I should go? All these remain a challenge in majority of the surgical planning. The extent of surgery, as I mentioned right at the beginning, it still holds that we perform a en bloc resection, and that includes the overlying skin, the surrounding tissue, maybe a centimeter margin, and underlying muscle if that's very close. What is important as a surgical advice for youngsters is that at no stage for these tumors I allow skin hooks for raising flaps when I'm removing phyllodes tumors. So I remove the whole tumor and then I might raise flaps to close. But at no stage the skin over the tumor, especially if it's phyllodes, I would like to save at all. It might amount to conservation with some kind of reconstruction. It might amount to a mastectomy. In either event, to do a conservation or a mastectomy is not the point. The point is to get a wide excision done. The series from SEER, as reported by McDonald's, 15% increase between 1988 to 2002 to wide excision alone and not a radical procedure. Margin controversy remains. There is data that say even with positive margins, benignity can be observed, and there have been recurrences even with 2 centimeter gross margin. It remains, but it is unlikely that we have left behind tumor and it has not come back. And a recurrent tumor in fairly good numbers remains not curable. So I will get into some slides as well as what we do and the predictors of these recurrence. This is an article which was earlier also alluded by many, by Lim, wherein the maximum recurrences were essentially related to either positive margin or very small, very close margin. So on one hand, you might have this. On the other, you might have studies wherein whatever you do, the smallest of the recurrence and there are no smallest of the margins and there are no recurrences. Multitudes of studies. I don't expect anybody to read this slide. Suffice to say that individual experiences put forth in retrospective analysis and there could be conclusions. What is important is that this is an individualized decision made by the surgeon. And if we collate that data, the conclusion has to be that the treatment has to be individualized. Because we have individualized, we have said this as our hypothesis or our postulate. And based on that, the data is collected. And then we say that, yes, it does conform to that. I doubt whether that's really true in real sense. But the local recurrence, there is a systematic review of the studies that I showed just now, showing very clearly that there is 8% recurrence in benign, 13% in borderline, 18% in malignant phyllodes. So there is a gradual increase as the genotypic change happens from benignity to a malignant tumor. And for each of those changes, from benign to borderline, there is doubling of recurrence, and there is from borderline to malignant, there is about 28% increase in the chances of recurrence. So all those, and in addition, the histology is an important aspect. In general, whether the tumor size will be a predictor at all will be decided by the data set. If the data set doesn't have a very large variation in tumor size, you are unlikely to get tumor size as a significant variable. But if you have right from 1 to 2 centimeter to about 20 centimeter and sizable numbers in all groups, if I were to say say 0 to 5 centimeter, 5 to 10 centimeters and above. In each of these subgroups, if there are sizable numbers, I'm sure tumor size will be significant in either event. And again, I would not get into conservation or mastectomy. I would get into how wider the excision is, whether it amounts to mastectomy or not, will depend upon the size of the tumor. Although this was again a meta-analysis for each of these, from benign to borderline, from borderline to malignant, I want you to focus onto the amount of heterogeneity amongst the studies. Hugely significant heterogeneity, putting on doubt as to how well these confidence intervals or reliability of these confidence intervals, and there could be overlap in each of these, casting doubt on our nomenclature of benign, borderline, and malignant phyllodes. So, suffice to say that the data is debatable. This is one paper that has raised huge amount of discussion, and the contemporary multi-center study of 550, I must say that the total number that is reported there is not 550, it is 545. But suffice to say that there are 70%, close to 70% benign, 20% borderline, and 10% malignant tumor. The median size, I want you to focus, that's 3 centimeters. A fair number of them, a small number of them were screen detected, fair number of them were noted by the patient herself, and there is a fair bit of positive margin. Not all positive margins were re-excised. And finally, the conclusion was that the margin status may not be of any great significance. But what is important is that if all margins are not dealt with surgically, I can't see how margins will have any impact there at all. So let's see how these things compare with the rest of the data that we have. But I again would like you to focus 70% benign, 20% borderline, and 10% malignant at a 3 centimeter size primary tumor. I get on to our own data of 433 patients. I'll talk about all of them. I would focus finally on 231 patients who are treated exclusively at our center. So there are 3 groups of patients that are treated out of these 433. One is exclusively treated at Tata Hospital. There are another 48 patients who were treated outside for excision biopsy, and they have come for a second opinion within 2 to 3 months of their excision, and we have done a wider excision of the primary site. And then there are another 154 odd patients who have come with a recurrent tumor following a previous resection. So those are not part of my discussion at all. But I would like you to look at the benignity to the malignant potential and finally some sarcomas. So we have 40% benign, 20% borderline, 30% malignant, and 10% sarcomas. Please understand this entity is extremely uncommon in the Western literature. And the primary tumor size, I would like you to note 6 centimeters. 48.3% of them all of them underwent oblong excision, but 48% had breast conservation. The rest had, so almost half of them had conservation, half of them had the whole breast removal. And if I were to look at the survival figures or recurrence figures, the disease-free survival, excepting sarcoma histology, the others were not significant at all. They didn't have any significant recurrence at all. And I attribute that to the oblong excision of the tumor done. These are tumors that are primarily resected at one center. If I were to include the individuals who have had previous biopsy, then the previous biopsy also comes as a significant detrimental determinant of recurrence score. These are not previous biopsy with a recurrence presenting to us. These are previous biopsies come to us with for a second opinion within 2 to 3 months of their primary surgery, and we have done a wider excision. So the tumor size is also quite comparable in these versus the 231 primary resection. I would now focus on to those who presented with primary tumor to us. They've had no intervention outside. A core biopsy confirmed the nature of the primary tumor. The median age was 45. The primary tumor size was 6 centimeter. The range was from 1 centimeter to 32 centimeters. All these are untreated patients, de novo for treatment at Tata Hospital. I would like you to focus on to benign tumors, borderline tumors, malignant, and again, sarcomas. 51%, half of them were benign. In the study that have been reported outside with a primary tumor size of 3 centimeters, this was 70%. This was 20% there. It is similar in our series. 20% were malignant. This was much smaller in that series. And this was 0%. 4.8%, about 5% are sarcomas out of on the final histology. The 44-month median follow-up and the 5-year disease-free survival was 92.1% in this cohort of patients. And if I were to use the outside excision biopsy also, then it drops down to by 10%. On a Cox regression analysis, only malignant histology for sarcoma continued to be significant. And as I mentioned earlier, the excision biopsy, if included, was also a detrimental determinant of long-term outcome. I want you to focus on to the 231 patients who had excision had primary surgery at our place, which was an R block excision after a core biopsy. 172 were benign and borderline put together. So a fair majority were those, and 48 were malignant. In them, in these 172, the primary tumor size was on an average 6 centimeter, that is the median tumor size, and the local recurrence rate at the end of 44 months of follow-up is 2.3%. Whereas in malignant, it is approximately 8.5%. And those who had excision biopsy outside, it is 12.4%. I am unable to see this one. Sorry. So for malignant, it is 14.6%. And for those who have had outside excision biopsy, it is 12.5%. So let's relook at this outside excision biopsy. I would like you to focus on to that. So the cohort 2, all put together, had 5.6% recurrences, which includes local plus distant, and 3.4% were the local recurrences. Of those had local recurrences, whereas those who were treated, operated outside, and then we had wider excision, that's the kind of local recurrence, and that's the overall recurrence, 12.5%. At the median follow-up, those are the numbers, a little typo here of the p-value, but driving home the importance of the accurate preoperative planning and an R-block wide excision with clear margins at the first surgery. So if I were to quote Dr. Mitra, he would say the first bite at the surgery has to be well planned and complete as far as excision is concerned, with a good, clear, wider margin. I would like a little comparison between the data that was presented with the 550 patients by Lim et al. And our own data of the primary surgery at TMH. Please focus on to the primary tumor size, 3 centimeter median, 6 centimeter median. Benign 70%, 50%, about 20% less. Borderline almost similar, 20% on either side. Malignant tumors 10.5%, 20%, double in our series. Sarcoma 0%, ours 4.8%. Now, having said all this, much bigger tumor size, much bigger adverse histologies, and median follow-up of 36.7%, 44%. The local recurrence, I'm only talking about local recurrence, 3.3% and 2.3% local recurrence in our series. I very strongly attribute that to the R block excision. And unless we do that as the first intervention, it's unlikely that we will get the kind of results that are seen here. These are sizable numbers. And again, if I were to describe that wide excision of R block excision, that no flaps to be raised till the time the primary tumor is out. From skin down to the muscle, the way you would excise a sarcoma. Phyllodes, as described, is leaf-like extensions in the surroundings, which if left behind, will come back and will come back with vengeance. So, surgery remains the cornerstone of management. However, several questions remain unanswered. That for borderline and malignant, we still recommend R block excision. One can debate about benign lesions, but I would further elaborate on that. Conservation is easily possible if cosmesis can be achieved with some kind of plastic surgery, but to compromise for cosmesis, to compromise excision for cosmesis is not acceptable at all. Wide margins are definitely required. How wide we can debate, but I think 1 centimeter is a good margin. But your widity is decided by whether you have raised flaps before the tumor is out. No question of tackling axilla in the armpit. That's another review that came in 2019 and 2020 about negative margins, histological type as a recurrence, heightened risk of borderline to malignant transformation every time there is a recurrence. This is an important aspect to understand. And I just now showed you with a rising tumor size, a drift to a worse genotype. And the recurrences varying from 4.7 to 30% and malignant having much higher local recurrence rate. So caution for even when something has been called benign. I come closer to my final slides. Accurate preoperative planning with R block resection is vitally important with clear margin. Recurrence appears to be related to the extent of initial surgery. So first bite at the cherry is most important and should be regarded as a failure if there is a recurrence as the primary surgical treatment. I want this third point to be read with reference to the first point, the first slide wherein I described what the pathologist mentioned in 99, in 2000. Where are we? Have we changed anything at all? Despite the host of biological markers studied, including grade, their use in defining clinical behavior and malignant potential remains limited. And 2016. There is a clear genotypic drift with increasing tumor size. So the phenotypic drift is coinciding with the genotypic drift, not just for size, but even for every recurrence. And with every recurrence, the possibility that we'll get rid of the tumor reduces remarkably. Something called as benign having 2 to 3% recurrence and borderline up to 10% recurrence. I want you to recollect our recurrences following conservation in infiltrating duct carcinomas. That's a cancer. That's a frank cancer wherein the recurrence might vary from 2 to 3% for smaller tumors to about 10% for larger tumors. How different are we from benign phyllodes to a borderline phyllodes? We are no different. And yet we want to call it benign as benign and the other tumor as infiltrating duct carcinoma, just because it looks under the microscope clearly a duct carcinoma. Whereas a benign tumor, phyllodes, in fact has all the features of benignity and yet has the potential exactly comparable to an infiltrating duct carcinoma as far as recurrence goes. So we need a global randomized study to address the extent of surgery, and that's possible. Within India, I'm sure there was Anurag Srivastav had floated this study. I'm sure we should be able to do it within the National Cancer Grid of limited versus R block resection, stratified by center, T size, histology, less. If we don't do this, we would be at the same place a decade from now where we were in 1980s. Thank you very much.
Thank you very much, sir. As always, very enlightening. And I think most would agree that essentially a surgical disease where there are two risk factors. One is surgeon, the other one is the pathologist. Because very often this benign versus borderline can get into real murky zones, and it is safer to err on the side of being surgically more radical. And I completely agree with you. Each recurrence is going to be worse than what was preceding, and with each recurrence, the distant metastasis, the incidence also keeps rising. And if it can be, like you mentioned, the first bite at the cherry, if it can be the best that you can offer, probably that will go a long way in saving the patient from this becoming an almost unmanageable disease when it comes as once or twice a recurrence. The excellent talk, sir, and the way you compare it, probably we need Indian solutions to Indian problems. These studies sometimes can be very confusing, and the analysis that you provided, we're probably looking at a totally different disease when it comes to our scenario. So we need that kind of an answer. And you're absolutely right in suggesting that we need some, a global, properly organized kind of studies, and I'm sure they're feasible. We are struggling with the numbers and maybe the institutional based practice. Each institution has its own individualized practice. But I am aware of this Anurag Srivastava when he started with this study, and we were involved in it, and he had sent a write up to Indian Journal of Surgery, and the pleasure of going through it. So thank you very much for such an enlightening talk.
Thank you.
Yes.
Any questions, Nija? They can be requested to put in the chat.
Yes, later. We'll take them later. So we can now invite Dr. Sanjit. Dr. Sanjit, over to you, please.
Yeah, thank you, sir, for the nice presentation, and thank you for inviting me for the data presentation. Can I share my screen, please? So can you see my screen? I am clearly audible.
Yes.
Visible and audible. Thank you.
So what I am presenting today is about the data, what we have done in our institute in Tata Medical Center, Kolkata, and I am presenting on behalf of the Breast Disease Management Group. And I am focusing mainly on the data because intention is to present the data, what we have done, what's our survival outcome, and how what I can summarize with our data. So coming to I have nothing to disclose about this data collection and the analysis. So what methodology we have used? We have included all consecutive patients with diagnosis of phylloids treated in our center. We have excluded sarcoma from this study. We have included the patient from 2011 to 2020. The data were collected from the hospital management system. So we have electronic hospital management system to deal with the daily clinical practice and institutional rate cap database. We have done the telephonic follow-up where we felt that the patient has not attended the OPD for last 6 months for the data collection. So we have collected the data about demographics, clinical pathological criteria, and treatment details. Disease-free survival and overall survival. So DFS was defined from the date of diagnosis to the date of recurrence or date of last follow-up. Overall survival was defined as date of diagnosis to the date of death by any cause or date of last follow-up. Analysis was using with the software SPSS and the Startup 14. So a little bit summary of what we do in the TMC, what's the institutional protocol for the phylloids. So mammography and core biopsy is generally done after clinical history and clinical examination. Staging in malignant phylloid only. We do CT thorax for the staging workup before going ahead with the surgical management. BCS option and if immediate breast reconstruction was discussed, if feasible as per the tumor size. No auxiliary staging was done in the journal. If the core biopsy is saying differential diagnosis as plastic carcinoma with malignant thyroid, and if we are doing mastectomy, we have done either sentinel lymph node biopsy and axillary lymph node dissection in few number of the patient. Margin criteria for benign, it was no ink on the tumor, and for borderline and malignant tumor, it was 1 centimeter. So as per if the margin came as positive, we have done surgery in all patients in borderline and malignant phyllodes. And we have discussed RT role in malignant phyllodes if the tumor size is more than 5 centimeter, and palliative chemotherapy was given for the metastatic disease. The follow-up was done clinically every 6 months and yearly mammography of the opposite breast. So coming to the results, all total 172 patients. All were female, and as we know that the phyllodes are very rare in the male, we have not seen a single male patient with phyllodes. The age-wise, median age was 46 years, and with the interquartile range of Q1 and Q3 is 36 and 53 years. The BMI was around 27. The tumor size, median tumor size was 7.5 centimeter with Q1 and Q3 of 5 to 12 centimeter. The median follow-up was around 36.4 months. So coming to the morphology, what type? So for the benign, it was around 30% in our series. Borderline was around 32.5%, and malignant phyllodes was around 38%. So this may be because we are dealing with cancer patient only in our setup. So maybe we have seen less benign disease in our series. So coming to the data of benign phyllodes, there are 51 number of patients. So the median age was 42 years. Median tumor size was 5.5 centimeter. We could have done wide local excision in 48 patients. The mastectomy was done for 3 patients, out of which 2 patients had immediate breast reconstruction, one with free flap and one with pedicle flap. In a third patient has not decided to go ahead with the reconstruction. Coming to the margin was negative in wide local excision patient in 44 patients, and margin was positive in 4 patients. And we have discussed cavity save in this group of the patient in all 4 patients, and ultimately we have done cavity save in 2 patients. Coming to the survival data, we had 2 local recurrence in 44 month of median follow-up, and 1 was in positive margin. So the recurrence rate was 4%. In the recurrence also, if you will see the pathology of the recurrence, there was upgradation in 1 patient from benign to malignant phyllodes in the recurrence. And in this patient, mastectomy and RT was given. In the next patient, the recurrence was benign phyllodes, and where mastectomy was done. Coming to the borderline phyllodes, around 56 patients. So median age is more close to the 50. It's 49 years. The tumor size was a little bit high or large, 8.6 centimeter median tumor size. We could have done wide local excision in 33 patients, and mastectomy was done in 23 patients. So deciding factor for wide local excision and mastectomy was, if you can see here, in the BCS group, median tumor size was 7 centimeter, and in the mastectomy patient, it was 15 centimeter. So margin was negative in 24 out of 33 patients, was positive in 9 patients, out of which 8 patients have re-surgery. 1, I think, lost to follow-up. So in the 5 had mastectomy as a repeat surgery, and 2 had cavity save. Coming to the survival data of borderline phyllodes, as you can see, almost same as benign phyllodes. 2 local recurrence. In the percentage-wise, it's 3.5%. 1 recurrence was in the positive margin, but we have done cavity save in this group, in this patient. And there is 1 patient has recurrent tumor as malignant phyllodes, where mastectomy plus RT was done. And the second patient has malignant phyllodes as a recurrence. We have done wide local excision plus LD flap plus RT in this patient. So median follow-up in the borderline phyllodes was around 36 months. Coming in the detail about malignant phyllodes, around 65 patients. So median age was 47 years. It's close to 50. If you will compare, I will compare all 3 groups all together in one table. So tumor size, median tumor size was 10 centimeter in malignant phyllodes. We have done wide local excision in 25 patients. It's combination of some patient had done wide local excision outside and came to us for the further opinion, and we have done local excision in some group of the patient. Again, the tumor size was determining factor for conservation surgery here. The margin was negative in 13 patients and was positive in 12 patients, out of which 8 had wide local excision outside. And I think it was done without core biopsy outside, and they had positive margin. So we have done the resurgery in almost all patients, and resurgery was mastectomy, and we could have done post mastectomy reconstruction in only 2 patients here. So even the reconstruction was very less in the malignant phyllodes group. That message I want to give. Coming to the radiotherapy, we have discussed radiotherapy option in all patients, and I will present the data how radiotherapy affected the survival or not. So 59 out of 65 patients had received radiotherapy. 1 patient had received chemotherapy post-surgery, and this was advised outside, and we during the collection of the data, we got to know that the patient had received chemotherapy as per the opinion done from outside. Coming to the survival data of malignant phyllodes, the median follow-up was 40 months, and you can see that there were 14 recurrences. So total recurrence is around 12.5%. Around 5% had isolated local recurrence where mastectomy was done, and 11 patients had distant metastasis. In the distant metastasis, you can see that it majority in the lung or lung and bone, but 2 patients had isolated bone metastasis. It was multiple bone metastasis, and around 13 deaths, 12 due to disease and 1 due to myocardial infarction in our series. So what we found that if the patient has the distant metastasis, average lifespan after diagnosis of distant metastasis very less is 4 months, range is 1 to 11 months. Probably there is no effective treatment once the patient is diagnosed with distant metastasis. So what we found that the local recurrence rate in malignant phyllodes in our group was 5%. The literature reports 8 to 10%, so it's a little bit less, probably due to radiotherapy. But when we have seen the data of 8-year estimated disease-free survival and overall survival, it's around 72%. And if you will see the literature of around 10-year data is between 70 to 75%. So probably radiotherapy has decreased the local recurrence rate, but not improved the survival. And what we found that all events are limited in the first year of the treatment, and 80% are within 12 months. So you can appreciate here the disease-free survival and overall survival. So graph is going down in the first 2 years. So its behavior is almost like an aggressive tumor or triple negative breast cancer, where you are seeing the recurrence is mainly limited to the first 2 years. So we have tried to associate the correlation between the histopathological and demographic factor with the survival, and there was no association with disease-free survival and overall survival with the mentioned parameter: age, pathological tumor size, mitotic count, use of radiotherapy, and type of surgery. So coming to the comparison between benign, borderline, and malignant. So this slide is very important. If we can see that the age of the diagnosis is benign is little bit 1 decade earlier, so it's around 40, and the borderline and malignant is around 50. Tumor size is median is 5.5 centimeter in benign, borderline is 8.6 centimeter, malignant is 10 centimeters. So in the malignant tumor, the size is generally larger than the benign tumor. Mitotic count, as expected, is higher in malignant phyllodes tumor. So breast conservation was done in 94% of the benign breast cancer patient. But when it comes to borderline and malignant, so in excluding where we have done mastectomy after positive margin in wide local excision, the breast conservation rate was 50% in borderline and only 20% in the malignant phyllodes tumor. So local recurrence rate, it was 4% for the benign and borderline disease, but around 5% with RT in malignant phyllodes. And you can see that the benign and borderline, I think the behavior is a little bit same. So borderline is more towards benign than malignant phyllodes tumor. Distance metastasis rate was around 17% in the malignant phyllodes, and the reported literature is also it's around 15 to 20%. So in summarize the data, what I can say that breast conservation can be done in suitable patient. So benign and borderline is generally of good prognosis. Malignant phyllodes has high distant metastasis rate. RT in malignant phylloid, yes, it decreases the local recurrence rate from 10 to 5%, but no effect on disease-free and overall survival. Early events are more common than late events. The first 2 years is very crucial, just like triple negative breast cancer. We have seen many bone mets, and bone scan can be considered with the CT thorax as per what I feel after the data analysis with the CT thorax. If you're not doing PET CT scan as a metastatic workup in the phyllodes. Systemic mets, if the patient will have systemic mets, if the patient is diagnosed with systemic mets after curative treatment, generally it's a very poor prognosis. So thank you with this, and I am happy to answer any question in the chat box.
Thank you, Sanjit. Wonderful. That was quick and crisp. So we will have questions at the end. You can
Yes.
them as we go along. I think we can move to the next one, Dr. Neecha.
Yes. Can we have Dr. Arwa? Dr. Arwa, you can start sharing the screen.
Okay. Can you hear me well?
Yeah, absolutely. Please go ahead.
Stop sharing. That's good.
Okay, just a minute. I will share my screen. Okay, thank you very much for the invitation, and I'm very happy to be with you today, the Asian Society of Mastology. I hope my presentation will be simple and concise and to the point. I will just highlight some experience from the European Institute of Oncology from Italy in Milan, and share some management currently in place. So the tertiary referral centers, the current management mainly rely on data from retrospective studies still, and from large center experience. So just a brief summarization: phylloid tumor are fibroepithelial neoplasm of the breast. On histology, they show a peculiar leaf-like appearance, and they account about less than 1% of all primary breast tumor and around 5% of all tissue sarcomas. They are classified as benign, borderline, and malignant, and majority of them are benign cases. So key points about those tumors: they are uncommon neoplasm, and they present in an older age group than the usual fibroadenoma, and they tend to present in large sizes than fibroadenoma, and malignant ones further larger in size. They characterized by the rapid growth, and they tend to recur locally, especially when they are diagnosed as borderline and malignant. So with regard to malignant phylloids, they are reported to be 10 to 15%, and the first malignant phylloid case was reported in the 1931 with metastases to the lung. They have a significant potential to recur locally and the ability to metastasize. They are uncommon and quite challenging, and remains the adequate surgical resection is the key to maximize local control. They have a high risk of metastasis, up to 16%, and they rarely respond to chemotherapy and unfortunately die within 3 years of initial treatment. Factor associated with development is metastasis, aggressive behavior, and importantly, the infiltrative tumor borders. So in tertiary centers, the management of phylloides tumor is essentially under the multidisciplinary team approach, and sometimes an input from the sarcoma MDT is essential. And with regard to surgical management, remains the wide local excision with a clear margin, or sometimes mastectomy in appropriate cases. There is no contraindication to oncoplastic and reconstructive surgery as long as we can achieve local control. Axillary lymph node staging is not required unless lymph nodes are involved. And as we know, that metastasis is usually hematogenious. So A cardinal rule for adequate resection margin is important to provide disease control, and it is a prognostic indicator and determines long-term survival. Still, in tertiary centers, we follow the guideline of the NCCN, so at least a 1 centimeter excision of margin is the standard approach. Unless we have an angiosarcoma, therefore, the standard margin goes to 3 centimeter to ensure no local recurrence, as long as the angiosarcoma tend to highly recur more than the malignant phylloides tumor. Some key factors about the local recurrence rate. So they tend to recur in all phylloides tumor, all subtype, and especially the malignant ones. And there is no difference found in terms of local recurrence between the patient treated with breast conserving or mastectomy. Regarding the adjuvant therapy applied in tertiary centers, still we don't have a randomized controlled trial to determine a consensus. So still in place as the result of prospective studies. With regard to adjuvant radiotherapy, it's sometimes considered for aggressive tumors and large size tumor, but it is discussed case by case. Chemotherapy is still not the standard of care, and the case by case discussion is for large tumor and higher tumor grades. It is applied for recurrent and metastatic disease, but without clear survival benefit. The role of endocrine therapy is limited because they don't express hormonal receptors. And recurrent and metastatic phylloides are treated with the guidelines, NCCN guidelines of sarcoma. The role of neoadjuvant chemotherapy is not yet established in tertiary centers because they are poorly responsive to neoadjuvant chemo and radiation therapy. So we proceed to surgery first, regardless of tumor subtype. I want to share with you one of the cases we have encountered, the biggest case of the malignant phylloides tumor in the European Institute of Oncology in 2020. So this is a patient presented with a rapidly progressive tumor, 35 centimeter at least. And the PET scan showed no metastasis. So upon multidisciplinary team recommendation, they recommended to proceed with mastectomy and immediate breast reconstruction with latissimus dorsi, flap. Post-surgical resection showed the right breast mass measuring at least 35 centimeter in diameter, involving or adherent to the muscle and overlying skin. So the MDT debated on this case and finally recommended no further chemotherapy, no further radiation therapy in spite of its large tumor size, and recommended a surveillance follow-up. Patient is still alive and no evidence of recurrence, which shows the debated role of the chemotherapy and radiation therapy even in aggressive cases. In general, reported survival ranges in the literature with 5-year survival rate ranges from 50 to 90%. So we don't have clear data. Questions for debate, still the 1 centimeter margin advised by the NCCN guidelines, while on the other hand side, since 2014, no tumor on ink is sufficient for the invasive ductal carcinoma. So either are we excising too much nowadays? So just to conclude, phylloides tumor is a rare tumor, and the malignant phylloides is still a very rare disease with no consensus in treatment, especially in tertiary centers. And reported evidence still shows they tend to recur regardless of their subtype. Thank you so much.
Thank you very much. I think that was very crisp, and of course, it covered up the European approach to the same disease. Maybe we can take questions now, Dr. Neja.
Yeah, first of all, can I go ahead with my set of questions?
Yeah,
so
that's why I said.
Yeah. So my question to Professor Badwe, sir. So how do you assess the margins, sir? You take out the tumor and wait for the final histopathology, or some kind of frozen section for determining the margins?
There are no frozen section. The whole tumor goes to the pathologist, and they then ink the margin. The whole specimen gets into ink, and they look at the margins separately. But again, as a surgeon, it's very clear that no flaps to be raised till the time the whole tumor is out. And a block resection of skin to the underlying tissue. If the muscle is closed, then the muscle too.
Right, sir. And the same question to Dr. Sanjit. So you said benign tumors, no ink on margin. So if it comes out to be less than centimeter, yes, for benign, if you're less than 1 centimeter, maybe you accept. But if it is borderline or malignant, you go back again and re-excise. So what is the first bite that you take? That is what I'm trying to ask, Dr. Sanjit.
For borderline and malignant, we are taking 1 centimeter margin. For benign phyloid, we are taking clinically 1 centimeter margin. But if histopathologically it's coming very close, or even if it is 1 mm or 2 mm, we are not doing cavity save or mastectomy in benign phylloids. But in the borderline and malignant phylloids, if it is less than 1 centimeter, even if it is posterior margin, we are removing big major muscle or underlying muscle.
Right. And the differentiation happens at the final histopathology, I suppose?
Yeah.
Not before.
Happen at the final histopathology report. So what, as a surgeon, we do, we take 1 centimeter margin in all cases.
Right.
You would agree that when it comes to cavity shave, it's kind of a very dicey situation. What is it that you shave? And all excisions are 3-dimensional, and as we understand, it's treated on the lines of a soft tissue sarcoma. So you want to go a plane away or plane deeper, right? So what were these cases where you went for the cavity shave? Was it based on your frozen section report?
No, this was means in the benign tumor, we are marking the tumor for the specimen marking, and if one margin is coming positive, we are saving the surface. So it's not about the saving in the borderline or malignant tumor. It's specific to the benign tumor, and we have done cavity save in only 50% of the patients. So we have not done even cavity save, even if the margin is positive in benign phylloids. For the borderline and malignant, if the BCS margin is coming as the positive margin, probably we are doing mastectomy, not cavity save.
Sanjit, that's why I was trying to ask you. See, we sometimes treat this disease with the IDC mindset. We are, therefore, that's where the trouble is, and that's what Dr. Badwe was also referring to. It's a different disease. We need to change that hat. So when you're saying cavity shape, generally in the IDC scenario, it is on the frozen section. These days that the tumor on ink thing is come. Earlier we used to take that margin. If it is narrow, we'll go for a cavity shape. That's what I was trying to ask you. So
cavity save is 1 centimeter margin. So if you will see there is a fair amount of data for breast conservation.
No, I'm not saying that. It's probably, I agree with you. What I'm saying is, in your study, was it done based on some frozen section, or it was done empirically? You just decided we'll take one more shave.
So we have done cavity save. So we apply clip in all breast conservation surgery, even if it is a malignant phylloids. We are giving radiotherapy. We don't know as per the final report, or as per the decision of the radiotherapy. So we are applying clip in the every surface. So if the cavity save is required, that particular area will be cavity saved. So we can identify the clip.
After the final histopathology, or based on frozen?
After the final histopathology, it's not about after frozen.
Okay, you'll go for re-excision of that margin. Yeah. That's what you're saying.
Re-excision with shave. Okay. And Dr. Arwa, one question to you also. Suppose there's a patient with benign phylloids, 5-6 centimeter, comes out as closed margin, less than a centimeter. So do you do frozen for margins? And second, do you go back again if it is a closer than centimeter margin and benign?
Regarding frozen section, no, we don't do frozen section for benign cases if it's non-benign prior to surgery, and for benign cases we don't go for further margin re-excision.
Okay. Right. Sir, can we take up other few questions?
There's one question which was, of course, addressed to Professor Badwe, but I think he covered it up. In any case, I'm sure he would like to answer that. Fibroadenoma versus the phylloids thing.
Yeah, the two-cut biopsy.
I mean, one is, of course, the pathologist usually would raise the hands up. I'm not too sure it's an equivocal case. So
this is a gray area for all the pathologists. It's difficult, but when they say something like a benign fibroepithelial lesion, it's mostly either a fibroadenoma or a benign phyllodes. I think we discussed this in the last one of the sessions.
Anyway, the question it was raised to mind to make it. Enucleation, is it a good surgery in any case? Whether it's a fibroadenoma or a doubtful phylloids. So, Badwe, since it was addressed to you, so I'm passing it on to you too.
Well, I guess for fibroadenoma, it's an absolutely perfect surgery. I don't see any problem in that. But if there is, I guess it is related to size. That if the size is large enough, then you might want to know beforehand whether you should be doing a slightly wider excision. And if, in spite of taking all those precautions, if the final pathology is phyllodes, you need to go in and re-excise. And as far as the cavity shave is concerned, we avoid that usually. What we tend to do is, without entering the cavity, we excise the whole cavity. As if there is a balloon inside, and I'm going to excise that without entering the balloon.
Thank you. I think that is what probably I was trying to know, because you can't just be doing a focused excision of one margin.
Yeah, not possible.
It's very different and difficult to do also. I think I find it difficult. Now, there are a couple of more questions which are probably answered already. Some questions were covered.
One is
radiation, yes.
The radiation part. They've asked whether does size impact the radiation?
So where would you recommend radiation, Dr. Sanjit? Although we had a session earlier on radiation.
For malignant phylloids, we are discussing radiation if the tumor size is more than 5 centimeter, not for benign and borderline phylloids.
For any size of
probable advantage, we don't know the exact answer. So in the malignant phylloid, RT is still debatable. So in some center it's practiced, in some center it's not practiced. But in our setup, if the tumor size is more than 5 centimeter, at least we are discussing radiotherapy with the patient for a little bit less local recurrence. But I think it will change with some randomized control trial. We don't know the answer about radiotherapy in malignant phylloids.
You've absolutely answered. In our MDM, we often find this coming up for recurrent phylloids and also for the size, as you mentioned, and the poor grade. Although nobody knows the one right answer. Dr. Badwe, any comments on that if you would like to?
Well, I entirely agree that in absence of evidence, it's been practiced. Since we are practicing, let's go ahead with doing that. But 5 centimeter plus malignant tumors, we do radiate. We do discuss if the patient is young enough with the radiation oncologist, would only a boost be good enough rather than the whole breast radiation. Again, they take their call, but I do feel that essentially it is for local recurrence. And if I were to cover about 2.5 centimeter of the whole area, then that should be good enough for preventing local recurrence.
A fair point. I mean, you can just target the area rather than covering the whole breast.
Absolutely.
Yeah. So that was one question, and I think most of the other questions were covered. Any comments on radiation or the other questions that were raised, Dr. Arwa, and the practice at Milan?
About what, radiation therapy?
Yeah, that's right. Your policy there.
Yeah, as you see, I have presented such a big tumor and no radiation therapy was recommended. So it's a discussion of case by case with the MDM, and in these cases we involve the sarcoma team in our MDM, but there is no evidence with regard to radiation therapy.
Right.
So if the margins are close, Sanjit, they were basically the question came up with the cavity shave only. I think you covered it. So you would go back, and if it is less than 1 centimeter, say it is 9 millimeter, they're trying to be difficult. So it is 9.2 millimeters. I'll make it even more difficult. Would it change your approach? What would you do?
So, what I will do, I will discuss with the patient if it is 9 mm and the institutional guideline is 1 centimeter, and I will discuss this in the tumor board. Do we really need to go back? Because if you will see the American Breast Surgery guideline published last year, they have published their guideline. So now they are taking 5 mm margin. They are not taking 1 centimeter margin.
But the T size is smaller, and that's where the catch is. And I think 1 centimeter is just about all right. We need to go even beyond it. Most of us do. And to be honest, we are always scared of the risk. It's basically a surgical disease, as Dr. Badwe very rightly brought out. So the best that you can offer is in the form of surgery, and no radiation is going to provide that cover later. So it's safer to be more aggressive with it in the first go. Later on, it's a terrible disease to handle, and one doesn't know what to do. I mean, there are, I think there was a discussion in the first webinar that we had about skin sparing, etc. So I think it's a fair point that you excise first. I mean, the resection shouldn't be with reconstruction in mind. It should be the other way around. So we should be resecting with an ablative intent. It's like a sarcoma that you're treating. So need to be aggressive surgically. Any other comments or questions, Dr. Nija, that I didn't find or you have found?
No, so almost everything is covered. I just noticed one comment. If the margins are closed, you need to radiate. No, there is no compromise over the margins. If the margins are closed and borderline or malignant, they have to
take it out.
Yeah, they have to be taken out.
Whenever in doubt, take it out. That is the principle that will work here. Now, there is a quick, tricky question there. BCS you've done, and we're all, we're always thinking BCS means radiation. So again, that IDC mindset. So would you be doing, subjecting the patient to radiation, Dr. Sanjit?
So for the borderline, no.
Any size?
Malignant phylloid, yes.
Any size?
Any size of borderline?
The malignant phylloid. So malignant phylloid, if you see the median tumor size in average 10 centimeters. So malignant phylloid, we are seeing very less number of the patient, less than 5 centimeters. So only 2 or 3 patients. So for borderline phylloid, we discuss radiotherapy if the size is more than 7 centimeters, but there is no fair evidence for using radiotherapy.
Sorry, Sanjit. Sorry. We wouldn't be offering conservation to such large tumors. So probably the whole idea of providing adjuvant radiation in breast conservation surgery is different. It's for the local recurrence. The rest of the breast, that is what you're looking at.
Yeah.
Here the concept is when you're thinking about conservation and radiation subsequently, you would rather go for a wider excision and resection. So that's the best answer that you can provide to the patient. So I think the take home should be clear. Otherwise, they'll go back thinking that it's like BCS you do in IDC. So it is different. So thank you. Thank you for that. Dr. Nija, any more questions? Otherwise, we can.
No, I think we can wind up. So we have had very exhaustive discussions, last 5, including this one, on the basically margins on fill loads. And I think Professor Chintamani sir will also agree that the deliberate attempt for any kind of fill loads is 1 centimeter. Going back again to re-excise in a closer margin for benign would be 1:1 discussion, or a surgeon's perspective after looking at the tumor size and how close you can follow up the patient, because you need to follow up the patient for a long-term minimum of 36 months. And again, make sure that the tumor is actually not a recurrent one, because many of the times you might miss a history of previous excision. So that is very, very important. Anything to add? I think we are done.
Brilliant. Actually, we had probably the icing on the cake happened today with Dr. Badwe coming in. And the take home is very, very clear, and it has happened at the right time so that the last words are remembered for good. So there's no point. I mean, it's good to be scared when you're dealing with phylloids, no harm, because for the sake of the patient, you shouldn't be, it's safer to be defensive. That means to be aggressive in management of this disease. And like another person has asked a question, 2 centimeter MPT patient wants mastectomy. Would it require radiation? I mean, again, the same thing. Radical surgery is a treatment, and there's no place for radiation to cover up for an inadequate or suboptimal surgery. With that, I think we can conclude it. Dr. Badwe, thank you very much for coming and making it very, very special. And it really sums up all our webinars into making some sense, and all of us can take home from today as to the guidelines that we need to follow are basically Western, and you need to find your answers to the questions that you have. Therefore, the need of the hour is to conduct multi-institutional, some kind of a study under the guidance of such eminent people that you have on the panel today, so that we can find our answers, and then you can tell the rest of the world also, our tumors are different, and this is the treatment for these tumors. So with that, we can close it. Thank you very much, Dr. Badwe, for having
Thank you so much, sir.
Very much.
Thank you.
Bye. Good night. Thank you.
Take care. So next session.